I'll be talking on is the visual acuity chart a good predictor of improvement in visual acuity with low vision aids? So I have no financial interest or conflict of interest in this presentation. The high contrast visual acuity chart has been utilized for visual acuity measurements since the time Snellen described this chart in 1862. There has been considerable debate about the use of other forms of testing, as it does not reflect the contrast that is available in everyday life. This becomes even more magnified in visually impaired patients where contrast sensitivity is substantially decreased. There is another method of evaluating the effectiveness of low vision aids in validating low vision, is the validated low vision questionnaire of life questionnaire, quality of life questionnaire, sorry. Wolfson et al. Designed the LVQL's questionnaire, and it has been shown to be an internally consistent, reliable, and fast method for measuring the vision-specific quality of life in the visually impaired in a clinical setting. It is a 25-item questionnaire with a maximum points of 125. So our aim was to find out whether the objective improvement that we see with low vision aids in the high contrast visual acuity chart correlates with the subjective improvement that is seen on the questionnaires in such patients. So this was a prospective observational study that was carried out at our institute. All patients referred to the low vision clinic were included after ruling out any treatable ocular condition, and those previously using low vision aids, having mental disabilities, or unable to understand the questionnaire, or those with no perception of light were excluded. The distance visual acuity assessment was done with the high contrast logMAR chart and or the E chart as required. The near visual acuity was done with the reduced Snellen's chart, and which was converted to M notation for the purpose of statistical calculations. For the subjective measures, the patients were instructed to answer a questionnaire before the trial of low vision aids and after the prescription of low vision aids at the follow-up visit at 1 month. The questionnaire has 4 areas of quality of life. We were interested in 2 parts of it, that is the mobility, distance, vision, and lighting part, and the reading and fine work part. In our definition, the objective improvement in visual function was assessed on the improvement seen with low vision aids on the high contrast visual acuity chart, which was subtracted from the previous visual acuity. And the subjective perception of improvement in visual function was assessed by the difference in LVQL questionnaire scores. For distance, it was the distance, mobility, and lighting part, and for near, it was the near and fine work part. For statistical analysis, we used a t-test for comparison of means, and two-tailed Spearman rank correlation coefficient was used to correlate the improvement. Statistical analysis was done using the SPSS software, and p-value of less than 0.05 was considered significant. So a total of 48 patients were included in the study. 2 were lost to follow-up. Of the 46, 27 were male and 19 were female. Average age was 29.2 years, and retina and uvea were the most commonest causes. If we come to the results in visual acuity, there was a significant improvement in distance visual acuity from 2160 to 2050, and there was also a significant improvement in near visual acuity from N14 to N8 with the use of low vision aids. Coming to the LVQL score, it also improved significantly from 65.84, the total LVQL score, to 76.82. The score for distance improved from 32.8 to 35.34, and the score for near improved from 10.47 to 16.36, and all were significant. So all these results were significant, but once we correlated them, we found that there was no significant correlation between the visual acuity improvement seen on the vision charts and the improvement seen in the quality of life questionnaire. This is for the distance, in which the Spearman rank correlation was 0.086 and with a p-value of 0.57, and for near it was again not significant with a Spearman correlation of 0.036 and a p-value of 0.81. So to discuss, traditionally low vision is defined as per the WHO definition, which includes visual acuity based on high contrast visual acuity chart, and based on that, patients are referred to the low vision clinic. And even when we prescribe low vision aids, it's prescribed based on the improvement seen on visual acuity charts, but other visual functions that are measured but are usually not applied in the management. And ours is the first study in our knowledge to compare changes in different subsets of the LVQL questionnaire with clinical outcomes of low vision aids. Other studies have found a significant correlation between the total LVQL score and clinical visual measures. However, it should be understood that a low vision patient with a better visual acuity will be expected to have better quality of life. However, the improvement, the main purpose of doing the questionnaire or giving low vision aids is to find an improvement. And if there is no improvement, then the improvement seen on visual acuity chart is not actually valid. So there are a few limitations, like non-visual variables like physical and mental health may have an effect, which we have not evaluated in our study. So to conclude, our study shows that LVAs lead to a significant improvement in both objective measures of improvement in visual acuity and subjective measures, but these improvements do not correlate with each other. That is, a patient showing improvement in visual acuity on HCV on the visual acuity charts may not show a similar improvement in his quality of life. So a low vision person able to read off our vision chart should not be our aim. A low vision person actually benefiting out of low vision devices should. Thank you.